Ever feel like you're drowning in medical notes? Just this like huge wall of text.
Oh, definitely. It happens.
Imagine just pulling out the absolute essentials. A clear guide.
That's the plan today.
Yeah, we're doing a deep dive into heart failure, using your revision notes to really lock down that key exam-friendly info. Quick and effective.
Yes, focusing on the core concepts. Once you get those, the rest falls into place much easier. We'll pull out those building blocks.
Perfect. So what's on the list? Well, the definition, obviously. Then the classifications.
Yeah.
You know, HFrEF, HFmrEF, HFpEF. Those LVEF cutoffs are crucial.
And the NYHA classification, too, the functional side of things.
Right. Symptoms, limitations for each class. Then causes, risk factors, the pathophysiology, like what's actually happening in the heart.
The sequence of events.
Yeah. And differentials, epidemiology, basically the high-yield stuff you need for recall.
And it's not just for exams, is it? Understanding this is fundamental to, well, understanding the condition clinically.
Okay, let's jump in. Definition first. Heart failure. Simplest terms.
The heart just can't pump enough blood for what the body needs, like a failing pump.
Leading to those classic symptoms.
Wow.
Fatigue, feeling breathless, maybe some fluid retention like swollen ankles.
And it's common. Your notes say, what, 1 to 3% of adults?
Yeah, but look at the over 70s jumps to over 10%. That age link is really striking. Definitely something to remember.
Good point. And it can show up suddenly acute or be a long-term chronic thing.
Now, that classification based on LVEF, left ventricular ejection fraction, the ESC one, this is like super important.
It really dictates a lot.
So first, HFrEF, heart failure with reduced ejection fraction. LVEF is 40% or less.
Reduced equals 40 or fewer. That's a neat mnemonic.
Then there's the middle ground, HFmrEF, mid-range, that's LVEF, 41 to 49%. And finally, HFpEF, preserved ejection fraction, LVEF is 50% or higher.
Right. And the key difference with HFpEF, it's often not the squeezing, the pumping out. That's the main problem. It's the relaxing, the filling phase.
Okay. Impaired relaxation. Why does this classification matter so much?
Well, like you said, it points towards different causes sometimes. HFrEF might make you think more about, say, previous heart attacks, ischemia.
Whereas HFpEF,
often more linked to things like long-standing hypertension, maybe age-related stiffness. So it helps guide, how we investigate and treat.
Makes sense. Okay, moving on to the NYHA classification. New York Heart Association. This is all about function, right? How it affects daily life.
Exactly. 4 classes. It maps out the limitations.
Class 1. Basically, you have heart disease, but it doesn't limit your ordinary physical activity. No real symptoms day to day.
Pretty much baseline, symptom-wise.
Class 2, though, you start to notice things. Slight limitation. They're okay at rest, but normal activity, maybe walking upstairs, quickly brings on fatigue, palpitations, maybe some breathlessness.
Yeah, that's the threshold where everyday tasks become a bit taxing.
Then class 3 is a definite step up in limitation. Still comfortable resting, but even like mild activity causes symptoms. Less than ordinary stuff.
Right, much more restricted.
And class 4 is the most severe. You've got symptoms even when you're just sitting there at rest. Any physical activity just makes it worse.
Unable to carry on any activity without discomfort. It's a spectrum, really. A useful way to gauge severity and track progress with treatment.
Good way to put it. A spectrum of function. Okay. Causes. Etiology. This list looks long.
It is quite broad, but we can group them. Big one.
Yeah.
Coronary artery disease, CAD. So MIs, ischemia, even arrhythmias stemming from it.
Okay. Hypertension's on there too. High blood pressure, especially if it's led to that thickening, the LVH, left ventricular hypertrophy.
Yep, that puts strain on the heart over time. Then you've got valve problems. Aortic stenosis, regurgitation, mitral issues, septal defects.
Right, leaky or stiff valves. And cardiomyopathy, actual diseases of the heart muscle itself.
Don't forget congenital defects, things people are born with.
True. And arrhythmias on their own can cause it too, right? Like atrial fibrillation.
Absolutely. Anything that messes with the heart's rhythm or rate significantly. Also conditions that just make the heart work harder overall.
Like an overactive thyroid or kidney disease.
Exactly. Increased workload. And surprisingly, some drugs. Your notes list things like beta blockers, calcium channel blockers, some antiarrhythmics, even certain cancer drugs.
Yeah, it seems counterintuitive for some of those, like beta blockers, which we use to treat heart failure sometimes.
It is, but in certain contexts, or if started inappropriately, they can worsen or precipitate failure. It's about the balance and the specific situation.
Okay. Then there are toxins, alcohol, cocaine, heavy metals.
Endocrine stuff too. Diabetes, Cushing's, pheochromocytoma, thyroid again.
Nutritional causes: thiamine, selenium deficiency, obesity, infections, Chagas disease, HIV.
Infiltrative diseases where things build up in the heart muscle. Sarcoidosis, amyloidosis, hemochromatosis.
Wow, okay. And finally, this concept of high output failure.
Yeah, where the body's demands are just too high for even a normal heart to keep up with long term.
So what causes that? Severe anemia, pregnancy,
Sepsis, hypothyroidism again, Paget's disease, beriberi, which is thiamine deficiency again, AV malformations. The heart might be working okay initially, but it just gets overwhelmed.
Got it. Okay, so risk factors. Who's more likely to get heart failure? There seems to be a lot of overlap with the causes.
There really is. Advanced age is the big one, as we saw. Having had a heart attack or other heart damage before.
Hypertension, diabetes, smoking, obesity, the usual suspects for cardiovascular disease.
Family history plays a role. Certain medications, like some chemo drugs, sleep apnea.
Alcohol or drug abuse, too. It's all kind of interconnected.
Definitely. These factors push the heart towards that path of weakening and dysfunction.
So let's quickly summarize the pathophysiology. What's the sequence inside the body?
Well, it typically starts with a weakened heart muscle for some reason.
Okay, weak muscle.
That leads to reduced ventricular function. It's not pumping as well.
Right. Less effective pump.
So the heart tries to compensate by working harder. Increased workload.
Which probably isn't sustainable long term.
Exactly. Over time, that can actually impair how well the heart fills with blood between beats. Impaired filling.
Less blood in me.
Less blood out. Decreased cardiac output. So the body isn't getting the oxygen and nutrients it needs adequately.
Weak muscle, reduced function, increased work, impaired filling, decreased output. It's like a chain reaction.
A vicious cycle, often.
Okay. Now, someone comes in breathless, tired, it could be heart failure, but what else should be on our minds? The differential diagnosis.
Absolutely crucial. Lung diseases are high on the list. COPD, asthma. They cause breathlessness too.
Pulmonary embolism, PE. A blood clot in the lungs, that's an emergency.
Definitely. Valvular disease, we mentioned it's a cause, but it's also a differential. Arrhythmias again.
And pericardial disease, problems with the sac around the heart.
Things like pericarditis or tamponade. You need to rule these other things out or identify them.
Right. Lastly, epidemiology. How common is this and who gets it? We touched on prevalence, but let's nail the numbers.
So in the UK, about 920,000 people affected. It's significant.
And the average age at diagnosis is 76. That really highlights the age link. The stats for age groups were stark.
Yeah, about 1 in 35 for 65, 74-year-olds.
Yeah.
Rises to 1 in 15 for 75, 84s.
And then roughly 1 in 7 for people 85 and older.
Wow. And across Europe, about 5 new cases per 1,000 adults per year. Overall adult prevalence, 1–2%, but again, over 10% in the over 70s.
And that split between HFrEF and HFpEF, HFmrEF.
Really important point. It's roughly 50-50. Half of reduced ejection fraction, half of preserved or mid-range. So you can't just focus on one type.
Good reminder. And the impact on the health service.
Huge.
Yeah.
About 2% of all NHS bed days are due to heart failure, and it accounts for something like 5% of emergency medical admissions.
That really drives home how significant this condition is.
Absolutely. So wrapping up, heart failure. It's complex, common, but understanding that definition, the classifications, especially LVEF and NYHA.
The causes, the risks, the pathophysiology chain reaction, what else it could be, and how common it is.
Gives you a really solid base.
Definitely. Those LVEF numbers under 40 is reduced, 41, 49 mid-range, 50 plus preserved, and the NYHA classes, I to IV, no limits to symptoms at rest. Key for quick recall.
You've got a great distilled overview now.
Hopefully that helps. And if you want to dive deeper, do more revision, tackle some practice questions specifically for the MSRA.
And over to passmsra.com.
And don't forget the free resources as well over at freemsra.com.